Welcome to the Explainer. Today we're diving into a parasite that poses a really unique clinical challenge, Strongyloides stercoralis. You see, this is a true master of persistence, capable of causing a silent infection that can lie dormant for decades, only to erupt into a medical catastrophe.
So this gets right to the heart of the whole strongyloids problem. And the answer is a resounding yes. To understand how that's even possible, we need to take a look at the remarkable biology of this parasite.
All right. Section 1. A parasite's secret life. To really get a handle on the threat, we first have to examine the parasite's unique life cycle. It's really the engine that allows it to persist for an entire lifetime.
Okay, so this diagram shows you the typical pathway for a new infection. You've got these infective larvae in the soil that penetrate right through the skin. They travel through the bloodstream, up to the lungs, get coughed up, and then swallowed. Once they're in the small intestine, they mature, and the females lay eggs that hatch into larvae and are passed in the stool. But, and this is a huge but, this is only half the story.
The real key to its persistence, the thing that makes this parasite so different, is autoinfection. You think, unlike other worms, strongyloids can reinfect the very same host. The larvae can mature to their infective stage inside the gut, burrow through the intestinal wall, and just restart that whole migratory cycle internally. This is the mechanism that drives a lifelong infection. Now, this table is fascinating because it highlights two completely distinct patient populations, even in a non-endemic country. First, you have this historical group of WW2 ex-prisoners of war. Decades after their exposure, they show a high prevalence and classic symptoms, like a specific kind of rash. Then, you have a modern group of migrants and immunocompromised patients where the infection is usually totally silent, completely asymptomatic.
Okay, Section 2. Unmasking the infection. So, given that these infections are often silent, with a really low parasite burden, what we call a parasitic disease, how can we reliably find this hidden threat? Well, this slide just nails the central diagnostic problem and its solution. Traditional stool microscopy, it's incredibly insensitive. It misses about 75% of chronic cases. It's just not good enough. In contrast, serology, which looks for the body's antibody response to the parasite, has a sensitivity of over 90%. That makes it absolutely essential for screening at-risk populations. So here's a proposed algorithm that gives a really clear, evidence-based path forward. You start with that high-sensitivity serology to screen people. If that comes back positive, it triggers a highly sensitive stool PCR test. Now that's critical to confirm an active infection because serology can stay positive even after a cure. And then use that same PCR as a test of cure after treatment to make sure you got it all.
So Section 3 is the susceptibility blind spot. We can find the parasite, sure, but effective treatment brings us to another challenge. What about drug resistance? Our main drug, Ivermectin, is great, but what happens if it stops working?
You know, our reliance on just this one drug makes this a really urgent question. Can we actually determine, in a lab, whether a specific infection is going to respond to treatment?
And the answer is, well, it's stark, and it highlights a major vulnerability. There is no standardized, clinically validated test for ivermectin resistance in strongyloids.
And the reasons for this are biological. The parasite's life cycle is just too complex to reliably replicate in a lab. And we don't have any established breakpoints to know what a lab result would even mean for a patient. Plus, a lab test could never replicate the complex dance between the drug, the parasite, and the host's own immune system. So what does that mean? It means we only find out about resistance after the treatment has already failed.
All right, Section 4, eradication and treatment. So, despite not having a resistance test, we do have a clear and effective treatment strategy. The goal is always the same: complete elimination of the parasite to remove that lifelong risk.
The standard treatment is ivermectin at a dose of 200 micrograms per kilogram. The drug works by targeting the parasite's nervous system, causing a paralysis that ultimately leads to its death and expulsion from the body.
Now, this table shows how the treatment really shifts depending on the severity. For a simple, chronic infection, you just need 2 doses of ivermectin.
But for hyperinfection, that's the life-threatening version, treatment becomes a daily regimen for at least 2 weeks, along with other supportive care. And you'll see a key point there is to rule out a co-infection with another parasite, Loa loa, before giving ivermectin, to avoid a potentially fatal side effect.
Okay, Section 5, Clinical Vigilance. In a country where this disease isn't endemic, prevention is a different game. It's all about identifying these latent infections in people before they have a chance to escalate.
And this is a critical point. There's no central surveillance system tracking cases. In a country like the Netherlands, Strongyloidiasis is not a notifiable disease. So the entire system of prevention really hinges on the awareness of individual physicians to even know when to screen for it.
This targeted screening is really the cornerstone of prevention. It requires a high index of suspicion for anyone from an endemic region, that historical XPOW group, patients with unexplained high eosinophil counts, and, this is the most critical one, any patient who is scheduled to start any kind of immunosuppressive therapy.
So, Section 6, Hyperinfection. Now we get to the consequences of failing to detect a dormant infection when a patient becomes immunocompromised. This is the moment a chronic condition transforms into a full-blown medical emergency.
Hyperinfection isn't just an increase in the number of parasites. It's a devastating syndrome that's really driven by a lethal triad of interconnected factors. So first, that autoinfective cycle just accelerates like crazy, leading to a massive parasite overload. Second, this is almost always triggered by immunosuppression, especially corticosteroids. And the third and most lethal part is sepsis. As all those larvae migrate through the gut wall, they literally drag gut bacteria into the bloodstream. It's this overwhelming gram-negative sepsis that drives the mortality rate up towards 90%.
Okay, so let's look at a case. Our first one really demonstrates the vital importance of taking a thorough patient history, one that might span decades.
So here you have an 85-year-old ex-POW from the Burma Railway. He was about to start high-dose steroids, which would have been a certain trigger for hyperinfection. But an astute clinician connected the dots, his exposure history from 70 years ago, his chronic rash, his blood work. They confirmed the diagnosis, held off on the steroids, and treated him with ivermectin, preventing a fatal outcome.
Our second case is a bit different. It highlights the power not of connecting historical clues, but of modern systematic screening.
This is just a perfect example of successful prevention. A 45-year-old woman from an endemic country was completely asymptomatic, with totally normal blood work. The only reason this infection was discovered was through a routine screening test before she started biologic therapy for her Crohn's disease. She was treated, she was cured, and she was able to safely start her therapy. A disaster was averted in a completely silent case.
These cases show that whether the clues are obvious, like a historical risk factor in a classic rash, or completely silent, the principle is the same. Clinical vigilance today prevents a catastrophic outcome that might be rooted in an exposure from a lifetime ago.
And this really leaves us with a final, powerful thought. Strongyloidiasis is not just some forgotten tropical disease. It is a parasite from the past that poses a clear and present danger today. Its unique biology creates a ticking clock in at-risk individuals, a clock that's accelerated by the very modern immunosuppressive therapies that we rely on so heavily. It demands our suspicion and a systematic approach to find it and eradicate it.